Healthcare consumers, providers, creators, and advocates. Health and wellness should be everyone's top priority, and it's a dynamic topic, complex and sensitive to a vast array of factors from a local to an international scale. The healthcare industry is now at the forefront of everyday life and hopefully on the cusp of a renaissance. We're glad you've joined us for this series that explores the ideas shaping healthcare. I'm Minta Ferguson, healthcare architect and director of the Strategic Facility Planning Group, McMillan Pasden Smith Advisors, and this is Ideas Shaping Healthcare. On this episode, I'm joined by Leslie Ravan, and we are going to discuss the modern trends and challenges of nursing education programs. Leslie Ravan has been practicing as a registered nurse for over 17 years. She received her undergraduate nursing degree from the University of Iowa and completed her master's degree in nursing with a focus on nursing education at Clemson University. Leslie is currently a senior lecturer at the Clemson University School of Nursing and is a certified healthcare simulation educator. Her professional interests include blended methods for best practice and delivery of simulation education, effectively teaching critical thinking skills to the concrete sequential thinker, and integration of web-enhanced teaching in the simulation setting. Originally a resident of Iowa, Leslie has resided in Greenville, South Carolina since 2008. She enjoys spending time with her husband and 2 children, reading and listening to almost any podcast in which true crime is the subject. So Leslie, just to get a little context here, I'm an architect, and when an architect goes to school, we get a lot of theory at school, a lot of pretty drawings and projects, but it's not until we graduate and then go work for a company that we get the hands-on experience where we actually learn how to really put a building together. And, you know, I work on healthcare facilities, I work on education facilities, and nursing schools are one of those things. And so when I think about when a nurse goes to school, you know, they have to have that hands-on experience before they graduate, before they toss their cap in the air. They need to know how to help people because they're working like directly with humans on the human body. And so just you can imagine a person wouldn't necessarily want to have a nurse learning how to do that for the first time after they've graduated. Today we want to break down some of the elements that create nursing education programs and specifically some things around simulation and the facility design of them and the trends we're seeing and where we're headed in nursing education. So Leslie, I know you've heard the saying, if it ain't broke, don't fix it. What are the tried and true things in nursing and in nursing schools that are fundamental? You know, what's worked in the past that still works now and we think is going to be necessary going forward?
I feel like excellent mentorship is a foundational concept for both nursing as a profession and nursing education. When the students graduate and they go out there and they start their careers, they're put on orientation for a certain amount of time and they're assigned a mentor that's tasked with training to orient them to the unit and what their job is specifically going to be. And we are finding that the experience that the student has, the new graduate has with their mentor really has a tremendous influence on the trajectory of that new graduate's career. And mentoring new graduates is going to be a lot like teaching. And we've all had a teacher that we could tell just really wasn't in it. And so it's crucial that new graduates are placed with mentors that really have a love for the profession. They want to do things right, even if it takes a little more time. They're ultimately thinking about what's the safest and most effective, best thing for their patient. And it's similar for new hire faculty that we have. We really need to have good mentorship in our educational programs so that we can grow those new faculty into their role. And it kind of begins to come full circle because the new faculty was once a new nurse and the new faculty is now an educator that's influencing the next cohort of future nurses that are going out there. So I would say mentorship is something that will always be around and be necessary.
It makes me really happy that the fundamental thing is that people connection. It is a human to human kind of thing. But in contrast, there's been a lot of technology change, particularly in healthcare, and so I wonder, maybe that plays a part in it. But what's changing in nursing education? I know with all the technology, probably equipment is changing. Is simulation changing?
Yes, those things are changing, and the reason for that is because the patients that we are seeing are changing too. I was kind of thinking about this, and my grandmother was a nurse also, but more like in the 50s, 60s, 70s. So what I see and what she saw are going to look very different if you put our job descriptions next to each other. But the biggest thing is that the acuity of the patient has changed. So the patients are coming to us having so many more secondary issues. When I began nursing, people would come in and they would have knee surgery, and all we were really worried about was the knee, the surgical side, the knee. They would have surgery, they'd stay a couple days, they would go home, and that was kind of the end of it. But now what is happening is there are so many secondary histories that are going along with this that I'm no longer, as a nurse, thinking about just the knee and the surgical site. I'm thinking about the fact that they're diabetic and that impairs wound healing, and I'm thinking about the fact that they have hypertension and that's affecting their ability to heal, and all of those things come into play. And so in education, we're having to match that when we're trying to teach our students about thinking critically and thinking of the big picture. They can't concentrate on the one little problem. A lot of other things have the potential to come up too, and so increasing the use of technology and simulation, we are more capable of training them more effectively.
Oh, that's awesome. So you mentioned that your grandmother was a nurse, and it was in the 1950s, which is a very different time than we're in now. Technology
Yes,
was
yes.
different, all of those things, and so nursing is different. And I think students back then were probably a little bit different too. I know that I recently was doing some mentorship in a high school for architecture students, and I wanted them to draw something. And so I wanted everyone to get out a paper and pen, and nobody had them. They
Nope,
only
nope.
had laptops. And I was like, oh my gosh, I don't know what to do anymore. But so how are students in nursing different today than they have been? And how is that changing how you create programs and simulation and education for them?
Right. Well, the age of the student is going to vary a little bit depending on what kind of program they're in. But if they're in a traditional undergraduate 4-year nursing program, your average age of student is going to be like 18 to 22 years old. And that means that they're falling into that millennial and pretty soon going to be that Gen Z type
Mm-hmm.
of learner. And the literature tells us that millennials and Gen Z, they want hands on, they want action. If it's not exciting, they're not interested. Um, Interestingly, too, they are critical consumers. So when they come to nursing school, they really do feel like they're a consumer. They expect all the bells and whistles, and part of that, you were talking about that they all pulled out their phones or their laptops, but they didn't have a piece of paper or a pen. We're seeing that they're very visual and tech savvy. And part of that is because we no longer have a generation of learners that has ever experienced not having a computer, not
Mm.
having their phone, and being able to take their entire life with them in a little box. I can remember when my mom bought our first computer and waiting for it, coming home every day and asking, "Is it here? Is it here?" And I think back to how little that computer could actually do compared to what things can do now. But that has affected our students quite a bit. And so it's also interesting, the majority of people that are our faculty that are teaching now are baby boomers, and the literature tells us about them that while technology is nice, it's not necessary. They teach in a much more traditional way. So, a challenge that we're experiencing in nursing education is that we either need to recruit educators that are closer in, closing that generational gap, so we're a little more like-minded, or we need to convince the traditional learning style teachers that they have to kind of go with what the student needs are, and the student should not have to, accommodate to them.
Are students, when they're applying for nursing school, are they looking for very specific things, very specific experiences?
I think that when they're looking, they might be interested in what maybe like your laboratory setting is going to be like. Do you offer simulation, and how robust is it? How, are you an accredited simulation center, or do you do simulation, but it may not be to the level that it potentially could be or should be. So they may be looking at stuff like that. They are also probably looking some at like boards and passing rates. It's a good benchmark. If we have really good board scores, you want to come to a nursing school where they're setting you up to be successful to take that NCLEX and pass your boards at the end of your program. So.
Yeah, I've been doing some research recently on designing cadaver labs, which I wasn't really that familiar with before, but I find it really intriguing, just to know that that experience exists for different students in the medical field.
Yes.
But I wonder, there's the lab experiences. Do students get to experience the settings in the hospital, say like on a nursing unit or in a clinic?
Yes, absolutely. In our program, the students, they come in as freshmen and they have all of their gen ed kind of things for the first 2 years. So as a first semester junior, they really get thrown into nursing. The rest of the curriculum is based around nursing. And part of that is starting in a fundamentals course that has a clinical and a lab component. And so they start out in lab and they spend 7 weeks in the lab learning kind of the basics, how to administer medications, how to feed a patient, how to bathe a patient, all the things that we can do for ourselves. But when you have to think about doing it for somebody else, there's actually a way to do that. So they start there, and that kind of slowly introduces them to what comes next, which is their first clinical experience. And so they go out traditionally to like a long-term care facility. So the patients do have medical issues, but they might not be like an acute issue at the time. And then they kind of progress through the curriculum, and through the rest of the curriculum, every semester there's one or more courses that have a clinical component to it. And as they progress, they get a little more complex. So they go from fundamentals to adult health nursing and go to more of an acute setting. And then they move on to our specialties. So that would be like obstetrics and peds and things like that.
Yeah, so they're kind of going up the stairs, if you will, in
Yes,
terms of specialties.
correct.
Yeah. Okay. So, during COVID, everyone went home. And we all kind of went virtual, including schools.
Yes.
And, hospitals stayed open, of course, and they were seeing this influx of patients.
Right.
But the clinics and things were also trying to do more virtual health and consulting over the phone or over a computer. And I kind of wonder, what was your experience with that? And is it changing how you're teaching going forward? And then is there also a way to relate that to perhaps what they'll experience in the field with technology and virtual health?
At the time that everything kind of shut down, I was in the part of my course where they only had 3 weeks left with me. So I was able to utilize some technology that we had. I had recorded a simulation that some faculty had done. So I was able to post that and kind of have them review it and reflect as if it was a debriefing experience. Our lead faculty for the lecture portion of the course, utilizes a textbook that comes with vSim software. Like they pay for that already. And she had been using it to make up clinical. And you have to make up clinical. So it was nice for like the onesie twosies that missed. You could assign them a virtual simulation and that would give them enough time to count towards their hours for clinical. So I was able to utilize that. And as far as like, am I still using it? Absolutely. I wish that it hadn't taken COVID. You know, if I could take that part of it back, I wish that it hadn't taken COVID to realize that, you know, there are a lot of ways to do things, and it has actually opened a lot of doors for us and a lot of potential to be able to accumulate hours, especially because one of the issues that we're running into is that it's difficult to place students, that sometimes the facilities, there are no places to put the students. And so some of the faculty that I teach with have started using virtual simulation or having them come to simulation like every other week, so they still get to go to the unit and they're still getting that hands-on experience, but then to make sure that all the students get that experience, they rotate them every other week. So it really works out, and I'm looking forward to learning more about using things virtually and learning online. But yes, I would say it's not going away.
Yeah, I was talking to someone recently who was mentioning that, when we think about rural healthcare, and even to the way that hospitals are setting themselves up now as a system. So they've got the hub and spoke model. So you have this maybe a tertiary quaternary facility, that's your acute care facility. It can handle strokes. It can handle all of the major emergencies. And then they have these smaller community hospitals out, say, like in different areas. And then perhaps they even have some other facilities out in more rural areas. But those facilities don't really see the same acuity of care as that main hub. So they're using virtual health to help I guess, fill the gap, if you will, between the competencies of the physicians or specialties that are at those rural or community hospital locations with what the resources they have at the hub. So I think it's something that they do in practice, but they probably, as you're learning virtually, you're building those skills inherently. So I think being able to balance that real life and the virtual is good with the example that you gave. On kind of taking into that simulation discussion, I've toured a lot of different hospitals across the country. So many of them have simulation labs as part of their education programs for nursing schools that they're partnered with, or even for their physicians to get their credits and experience hours going forward. And some of them are set up very differently. And I know that there's kind of a best practice to going through a simulation and talking about it afterward. And so making sure you have the right spaces to do that is critical, but also how the spaces are set up to create a realistic environment is pretty important. Would you mind talking through what is that best practice? What does that look like, and how do those spaces support that?
So to make a simulation experience effective, we would identify the objectives of the simulation and then choose whichever simulation is going to meet those objectives, or write a simulation to do that. And part of best practice is to pre-brief them, and that is sort of where the space comes into play with the students as well. We can pre-brief them before they come with videos or things that we want them to complete, so that they have those objectives and they have some ideas about what's going to happen in the simulation. But then part of the pre-briefing actually occurs in where the participants of the simulation are going to be. So I would say that you need 3 major spaces. One is going to be the actual patient care area, where the students are going to be to participate and take care of the patient. From the patient care area, there needs to be a control room so that someone can be running the simulator, the mannequin, and responding to what the students are doing. And those two areas need to be separate from a viewing room, or you might hear it called a debriefing room. And, you know, best practice has kind of evolved, and simulation space wasn't always paid attention to. But best practice tells us that the person that's leading the debriefing, that's facilitating the simulation, should not be the same person that's operating the mannequin. So that's one reason that those spaces need to be separate. That's so important because the biggest component of simulation, the biggest takeaway, comes from the debriefing process that happens at the end. And so if someone is left to run the mannequin, answer questions on behalf of the patient for the students, and do these multiple things, their debriefing is going to get very watered down because they're not going to have as good of a grasp at what went well, what didn't go well. And so those two things need to be separate. The viewing room, you of course, with the control room, you want it to be where they can see the patient, separate from the debriefing room. The debriefing room needs to be set up so that whoever is viewing, it might be on a screen. Some facilities set it up so that there's a mirror for the students that are participating, but we can see into the room, or we can project that onto a screen for them to view. So once you've got that debriefing room kind of set up, when they're viewing this simulation, they might sit in a row, they might, kind of arrange themselves however, but it's important then when you're creating that room that there's space for when the participants come and meet with the observers, that you can kind of set it up in a round table sort of way. And you can do that in a lot of different ways, but my advice is to make everything movable so that you're not stuck with one configuration, because when you're debriefing, you want to give everybody the same kind of attention and be able to talk to each student and have everybody feel like they're participating. You don't want corners that they can kind of get themselves into.
So Leslie, the patient room itself, where the simulation, the team is working, you want it to be as real as possible to the actual environment. So could you maybe describe to what links you go to make the simulation realistic?
Yes. So one of the most difficult things about simulation, the first thing that makes it ineffective is if the student perceives it to not be real. And so we do all sorts of things to try to increase the realism for them. This could be something like having a phone at the bedside so that they can pick up the phone and call a provider and somebody actually answers them on the other end. Sometimes we put patient family members, somebody plays the role of a patient family member. That's extremely realistic. Pre-COVID, it wasn't unusual to have a couple of family members in and out of a patient room all the time, and they have questions and they want to know what's going on, and in certain situations they get very upset or scared. And so as the nurse, you have to manage your time and take care of the patient, but you also kind of have to take care of the family member. Most rooms are set up with monitors that are going to beep and make noise, so they kind of adjust to like what the vital signs are doing. So it's kind of funny because if a patient's like oxygen is dropping and the students aren't paying attention to it, suddenly it starts beeping and they're like, oh, I need to pay attention to this. So there are a lot of ways that we can do that.
Wow, that's really cool how you're able to do that. I know I've seen a couple different locations and they can pump in smells, and it's really
Yes.
phenomenal what all you can do with that. And I think about the nursing schools, so you're able to create these lifelike environments, and you would like to get this collaboration with providers and nurses who are practicing in actual healthcare settings. So when a nursing school is perhaps building a new facility, are there pros and cons to being on a medical campus as opposed to an academic campus?
Yes. I would say that someone that's building a school of nursing being on a medical campus versus an academic campus would have a little more of an advantage. But it all is going to kind of come down to communication and that collaboration. Not that someone in an academic setting couldn't reach out and make that experience happen, but at my university, we actually share a space with a medical school. So they're using the space, we're using the space, so we're kind of crossing over anyway. It's really nice, like intra and interprofessional experiences are kind of the buzz right now, and so we're really trying to create that because it keeps us out of our silos in the medical profession, and it gives us a little insight into what the other person is doing and what their role is, and it ends up making us more effective when we're taking care of the patients because we kind of aren't focused on just our piece, but we know more about what the other players are doing.
Gotcha. And then kind of on that, also that human scale, a lot of companies right now are trying to address equity, inclusion, and unconscious bias. And so, a lot of professions also have these stereotypes about who they are. Historically, architects have been men, and nurses, the stereotype is that they are women. So how, what are schools doing to encourage men to be in the profession? Are they doing anything differently? And then, how are they creating that inclusivity and participation from the whole community?
That's a great question. There certainly are stereotypes that are out there. Traditionally, women are the nurturers, and that is how women are viewed in nursing and healthcare. I think that as a school of nursing, one thing that we try to do is we try to recruit male faculty so that when students are looking at going to school somewhere, that they might see those male faculty and say, well, I can envision myself there. There are men in nursing there. And I will say that we have had the number of males in our nursing program increase quite a bit in the last 5 or 6 years. So it's a slow
Awesome.
trend, but hopefully it's getting there.
Oh, that is great news. That's awesome. Well, thank you so much, Leslie, for joining us today. And you've given us a lot to think about and maybe even incorporate in some of our future projects and for others as well to consider. So thanks.
Thank you.
This is the Pulse Check, where I cover a few takeaways from this episode. 1, the way students are learning and consuming information is quick, active, and adrenaline-driven. This creates a need and changes for how educators teach and provide instruction in a variety of platforms and spaces. The second, mentorship and human interaction is still a focus for education despite advances in technology, which are also beneficial. And finally, the design, choreography, and setup of the simulation experience room, control room, and debriefing or observation room is critical to the success of the learning outcome. Thank you for listening to Ideas Shaping Healthcare by Idea Exchange. If you have any questions on this podcast, you can find our contact information via a link in the description. Thank you for tuning in to Ideas Shaping Healthcare, an Idea Exchange production brought to you by McMillan Pasden Smith Architecture and Advisors.